Hello, Assalamu alaikum. Today we are going to study about the obstructive lung diseases, from which our learning objective would be emphysema, chronic bronchitis, asthma, and the bronchiectasis. First of all, what is an obstructive lung disease? Obstructive lung disease are those in which patient is unable to breathe out. So O for obstructive and O for out. He is unable to take the air out. He has problem during the phase of expiration. So this is the basic concept which you should remember always. And this is not fully reversible. And the second thing is we are on our first condition, emphysema. What is emphysema? Emphysema is a condition in which the alveolar sacs, which you may have learned in anatomy, alveolar sacs are are the part of the lungs, and they take the air in, and they have blood capillaries surrounding them. So they do the whole gaseous exchange, and they are the most important part of our lungs. So what happens, they have an ability to recoil. So whenever you breathe in, while breathing out, those alveoli contract. So that contractibility or recoilability of the alveoli is diminished because of the destruction of their wall, and that condition is known as emphysema. So there are multiple etiology of emphysema. Etiology means the cause of emphysema. So emphysema is caused by smoke, tobacco smoke, or marijuana smoke, or air pollution, and the manufacturing fumes. If someone is living near industrial areas, they are prone to get emphysema. Alpha-1 antitrypsin deficiency. So these factors are going to contribute to emphysema. There are 4 types of emphysema: central SNR, pan SNR, distal SNR, and the irregular SNR. These are the types defined as per which part of the alveoli or which part inside the lung is affected, or which cells inside the alveolar sacs is going to be affected. So let's see. Central SNR is common in more than 20% of the emphysema cases, and here the central portion of the SNI is going to be affected, which is formed by respiratory bronchioles. Okay, and it is usually caused by cigarette smoking, and if it is too severe, it can lead to alveolar sac problems. So here is pan SNR. Pan SNR, panlobar emphysema, is usually occurring in the lower lobe of the lungs, or lower zone of the lung. So SNI are uniformly enlarged. Here we have the SNR cells themselves uniformly enlarged, but the fact is they are enlarged from the respiratory bronchiole, the bronchiole part, to the terminal of the alveoli, and it is usually seen in alpha-1 antitrypsin deficiency, which is a genetic factor. Due to genes, you are going to have alpha-1 antitrypsin deficiency. Distal SNR. Distal SNR emphysema is the proximal portion of the SNS is normal, but the distal part of the primarily is involved. So distal part of the SNI is primarily involved in distal SNR. So the name itself suggests that what it is affecting. Previously we studied in central and pan SNR that in pan SNR it was from bronchioles to alveolar sacs, and here we have a proximal portion. The whole proximal portion of the SNS is involved. There is no non-cause and spontaneous pneumothorax in young adults. Characteristic findings is multiple contagious enlarged air spaces ranging in diameter from 0.5 mm to 2.0 cm. Sometimes it forms a cystic structure with progression are referred to as bullae. Then we have irregular emphysema. In this type of emphysema, all the previously studied locations can be affected, or any one of them can be affected, or any two of them can be affected. Pathogenesis is that if a smoke is penetrated inside the lungs, have had an exposure to the lungs, the lungs forms reactive oxygen species, which we call free radicals, because we have oxygen inside the lungs and then we have tobacco inside the lungs. So what happens, there is an immune reaction which is induced because of that free radicals, and they come onto the walls of the alveoli and cause tissue injuries. Now, there is another factor which cause these injuries and this immune response to be more injurious to the alveolar sac. That is that the free radicals which are produced, they inactivate the antiprotease, or if the patient have alpha 1 antitrypsin deficiency congenitally, that also causes this procedure to go more and more, the immune response to go hypersensitive, to get like on an upper scale and produce damage to the alveoli. So here is the inactivation of the antiprotease enzyme. Now, protease enzymes are responsible for stopping that immune response, stopping the damage which is being caused by the neutrophils. But this is not the case here if a patient is experiencing emphysema, because the antiprotease enzyme itself is inactivated. Here is another chart explaining the same thing. So we have environmental exposure and then the genetic factors. Both of them lead to that inflammatory response, causing death of the necrotic tissue or necrosis of the epithelial cells, and mesenchymal cells have the decreased contraction and impaired proliferation and the decreased matrix synthesis, which in turn causes decreases the recoil ability of the emphysema, and that's how the alveolar parenchyma are destructed. Clinical features of emphysema. So we have dyspnea, breathlessness, and FEV1 is a forced expiratory volume in 1 second to forced vital capacity. Both the things, the ratio between the both is decreased. In emphysema, you will be seeing to a barrel chest shape, just it's like a drum-like shaped chest is formed from the AP view. The anterior and anteroposterior thorax cavities are expanded. Prolonged expiration, the patient may be sitting in a tripoding position so that he can help himself take air out of the lungs. Dyspnea and hyperventilation. So emphysema is also known as pink puffers because the ventilation is not disturbed. SpO2, which is a saturation, oxygen saturation, is going to be almost normal, but not 100% normal, but it's still better than the in the case of chronic bronchitis. Chronic bronchitis is known as blue bloaters, as it causes the skin to have a bluish coloration. Secondary pulmonary hypertension develops gradually. So that's the implication. If emphysema is not treated, then you get hypertension. And when you get hypertension, you are going to get cor pulmonale because of the failure of the right heart, because a lung is not functioning properly. Coma is also a thing which you can experience as a complication of emphysema, hypoxia, which is obvious, and the pulmonary failure with respiratory acidosis. Then we have chronic bronchitis. So chronic bronchitis, the name suggests chronic means long term, and the bronch means bronchioles, and the itis means inflammation. So it is a long term bronchioles inflammation. And when there is an inflammation, there is irritation, and when there is irritation, there is some sort of contraction in the airways, just like as in asthma. So here we go. Chronic bronchitis. Chronic bronchitis is common in people with the age of 40 to 65 years, heavy smokers or pollutants. Diagnosis: presence of a persistent productive cough for at least 3 weeks in consecutive 2 years. So this is a very good diagnostic parameters that the person is going to experience 3 months of cough with 2 consecutive years. Early stage mucoid sputum, there is a sputum, and later stage intermittent bronchospasm and wheezing. So at early stage the patient is going to be like a person 40 to 65-year-old, and they are going to have long term, we can say more than 40 days, a cough which do not resolve and is occurring from long term, and they are also having, it is also a productive cough. Pathogenesis of chronic bronchitis is irritants, hypertrophy of mucus glands in trachea, and hypersecretion of mucus, and a marked increase in mucin secreting goblet cells. Goblet cells are increased. Mucus glands are hypertrophied because they are doing the hyperactivity as well, and there is some sort of irritant available. And the mucus is secreted too much because the glands are active, as well as the goblet cells increase. Small airway disease and coexist, and secondary microbial infection. Infection is going to be also a thing found in chronic bronchitis. Prominent cough. Cough is very prominent. Sputum is also persistence without ventilatory dysfunction. Ventilatory dysfunction is not present. You can breathe even while having the sputum inside your lungs. Hypercapnia, hypoxemia, and in severe cases, cyanosis, as I told you. Blue bloaters. Complication of chronic bronchitis. Pulmonary hypertension, cardiac failure, recurrent infections, and the respiratory failure are all the complications which are caused by chronic bronchitis, which is pulmonary hypertension, cardiac failure, hypertension, with it's similar to the emphysema. Now, there is another point to be noted, that chronic bronchitis and emphysema are distinguished under one single term, which is known as chronic obstructive diseases, pulmonary disease. So in this disease, you may get emphysema dominant condition or a chronic bronchitis dominant condition. So that's why we are differentiating the two, because you can have chronic bronchitis dominant or the emphysema dominant. In COPD, both the things are present at the same time, but some people are going to experience bluish coloration, saying that we are chronic bronchitis dominant, and some will have pinkish or no bluish coloration, and they are going to say we are emphysema dominant COPD. And this is a practical example of people with emphysema. Left side is with emphysema. This guy is having emphysema, and this guy is having chronic bronchitis. Because of the use of accessory muscles, he have become quite weaker, while that guy is not that weak, and that's the difference. And there is the coloration. You can see that bluish coloration on his stomach, the patient with the right, and the patient with the left have pinkish coloration. The nose is a little reddy, and that's some distinguishing features in a practical life. Asthma. Asthma is a chronic inflammatory disorder. Due to it is episodic, and it also have certain, we can say, allergens. So these are the factors due to which the bronchioles go into spasm, they go into inflammation. The patient will experience wheezing sounds, and tightness and cough. Further, there are two classifications of asthma: atopic asthma and non-atopic asthma. Atopic asthma is the one which is no, not the one, but it's another type. Drug-induced asthma and occupational asthma. These are the four different classification of asthma, and the bronchospasm in asthma can be diverse, can be triggered by a lot of mechanisms. Mainly, the common mechanism is the environmental exposure to the smoke, fumes, cold air, stress, exercise. Atopic asthma is most common, and it is due to type 1 IgE antibodies. So they mediate a hypersensitivity to certain pollen grains or anything, whichever the patient is allergic to. Positive family history is found positive. Environmental antigens, it is triggered by environmental antigens such as dust, pollen, animal dander, and foods. Infections can also be a trigger point. So infection, if you get sometimes people with asthma say that whenever I get an infection, whenever I get cough due to fever, after the infection is over, I still get my cough, and cough do not resolve without taking the medication of asthma. A skin test, immediate wheal and flare reaction, diagnosis based on serum radioallergosorbent test that identify the presence of IgE specific for a panel of allergens. So you get a lab test for the allergens, so that tells you that the person's IgE antibodies are reactive to this, and this thing. And there is a skin test as well, which is the flare reaction. Skin is reactive to certain stimulus. Non-atopic asthma have no evidence of allergen sensitization. Skin tests are usually negative, and the family history of asthma is not really common. Respiratory infections due to viruses and inhaled air pollutants are common triggers for non-atopic asthma. It is thought that virus-induced inflammation of the respiratory mucosa lowers the threshold of the subepithelial vagal receptors to irritants. Humoral and cellular mediators of airway obstruction are common to both atopic and non-atopic variant of asthma, so they are treated in a similar way. It's actually having a similar mediators virus induced inflammation. So the inflammation is same. That's why both the atopic and non-atopic asthma are treated in the same way. But they do not have a history of allergen, but still the pathogenesis is similar. Not the pathogenesis, but the whatever the triggering factor is. After that, the triggering factor, the condition is same, so the same treatment can be used. There is one more thing, which is drug-induced asthma. So the bronchospasm or bronchoconstriction due to a drug. So here we have a common drug known as aspirin. Patients with aspirin sensitivity present with recurrent rhinitis and nasal polyps and urticaria and bronchospasm. Precise mechanism remains unknown. Mechanism is not known yet, but it is presumed that aspirin inhibits the cyclooxygenase 1 pathway of arachidonic acid metabolism without affecting the lipooxygenase route, thereby shifting the balance of production toward leukotriene that cause bronchial spasm. Then we have occupational asthma. It is really common for the traffic police workers to get asthma, and that's because they are very much exposed to everything around there, because there are cars coming and going by, and multiple times there are trucks taking away some industrial products from one place to another, and they are every time available at the roadside, getting exposure to as many pollutants as possible. So that's how they can also develop occupational asthma. Clinical features of asthma is severe dyspnea and the wheezing and hyperinflation of the lungs, and this condition is actually episodic. So if a patient is coming to you and he's looking like a normal patient, but he has a history of asthma, you ask him to go and do 10 minutes of treadmill as a physical therapist. So he will do 10 minutes of treadmill very normally without any exacerbation. But in some cases, there are people who are coming with an exacerbation or episode of asthma, and they are also the case of asthma, but you ask them to do a 10-minute treadmill. After the 10-minute treadmill, they are gonna put 5 puffs of their inhalers in their mouth to control their exacerbation. So that's a different thing, and that shows the nature of this disease. It is episodic, which is episodic. Spontaneously or with therapy, usually bronchodilators and corticosteroids. We usually suggest these people to use bronchodilators or the corticosteroid. Bronchodilator works on the bronchospasm, and corticosteroid try to reduce the inflammation. Spirometry can detect the asthma Occasionally, a severe paroxysm occurs that does not respond to therapy and persists for days and even weeks. Status asthmaticus. If there is a severe uh, dysfunction and severe problem, then we call it status asthmaticus. Hypercapnia, acidosis, and severe hypoxia may be fatal. Then we have bronchoectasis. Now, while studying bronchoectasis is a permanent dilation of bronchi. It is also a dilation of bronchi. Emphysema was also dilation of bronchi. But the fact is that this dilation is irreversible, as well as this dilation is not due to the destruction of the alveoli. Bronchioles caused by destruction of the muscle, and this thing is on the bronchioles, and that one is on the alveoli. So that's one of the biggest difference in emphysema and the bronchioles. But it is going to be difficult to differentiate it between the bronchitis and the bronchiectasis. So bronchitis is the thing in which you have mucus production, as well as you are here we have the mucus. But bronchiectasis, in bronchiectasis you are going to get blood in the sputum, while in bronchitis you are not going to get the blood in mucus. So muscle and the supporting elastic tissue resulting from or associated with chronic necrotizing infection. So you get infections and you get the problem with the muscles of the bronchioles. Secondary to persisting infection or obstruction caused by a variety of conditions. It is a secondary condition caused after an infection such as tuberculosis or the cystic fibrosis. Characteristic symptom: cough and expectoration of copious amount of full purulent sputum. Diagnosis: patient history plus radiograph bronchial dilation are enough to diagnose the bronchiectasis. Etiology of bronchiectasis is bronchial obstruction, that there is an obstruction of bronchi. Congenital or hereditary conditions are in cystic fibrosis, in immunodeficiency state, and Cartagener syndrome, which I don't even know what it is, but it is an example, so it's here. Necrotizing or suppurative pneumonia. Pathogenesis: two processes are crucial: obstruction, chronic persistent infection. So first we experience an obstruction, and then there is an infection, and a pathogen just enter inside our nose or through the airborne condition, and it go and irritate our airway and make cause an infection over there and enjoy the life. Either of these may come first, usually affects the lower lobes bilaterally. So bronchiectasis usually affect the lower lobes bilaterally. TB is also a condition which causes bronchiectasis. Clinical features of bronchiectasis: severe persistent cough with expectoration of mucopurulent, sometimes fetid sputum, sputum flecks of blood, frank hemoptysis, which I already told you that you will find blood in the sputum of bronchiectasis, which you are not going to find in chronic bronchitis or COPD. Symptoms are episodic, precipitated by upper respiratory tract infections or new pathogenic agents. Clubbing, hypoxemia, hypercapnia, and pulmonary hypertension and cor pulmonale are rare. Complication: metastatic brain abscess can be formed after a bronchiectasis. Reactive amyloidosis can also occur. And this is the end of this video. Thank you so much for watching. There is the references. Robbins Pathology 9th edition is the book, and internet is the source of all the images. Thank you so much for watching. Allah Hafiz.